you're seeing is highly likely to have had something surprising occur that day. They weren't expecting to suffer a trauma, they weren't anticipating their severe cardiac chest pain, so the earliest point that we can alleviate that suffering, the better for that patient. And the contextual way of doing that is to assess the level of pain, either via a numerical score or a smiley face, frowny face for kids, or even just referencing it to that patient's worst pain ever. How close to that are you feeling just now? And then matching that pain level that you've assessed with the agents or techniques at your disposal, giving the right dose of the right medication or titrating up a dose to find that, as opposed to just matching random drug to random pain. Now, before we get on to drugs, I'd like you to also have in your mind that reassurance, psychological engagement with the patient. They are in distress. Any form of reassurance is likely to be of benefit to their overall pain state. So informing your patient of what's going on, reassuring them that you're very much on their side, letting them know what's going to happen in the future. If you're heading to hospital, the ambulance, if there's going to be a transfer or a movement, letting them know all that stuff ahead of time so they feel informed and reassured is going to make their pain more bearable. And in terms of non-pharmacological techniques, it's also worthwhile thinking about that in the trauma scenario, most people are sore when they move, whether it's a limb injury, a wound, or even visceral pain. Keeping them still and doing sensible transfer techniques is likely to reduce their overall pain burden. And if we are talking about fractures, dislocations, wounds, I'd like you to particularly think about splintage. Splintage from your packs, simple splintage that you don't even need specialist equipment for. So even if that's limb-to-limb splintage, even if it's a simple bandage to keep an upper limb still, anything you can do to reduce movement is going to have significant analgesic effect. So moving to the pharmacology, let's talk about what you can use and what you should use. So simple analgesia following the WHO ladder would start us off with paracetamol, anti-inflammatories, moving our way up into opioids and other agents. I'd like you to have that approach in your mind because certainly the sooner you start with simple analgesia, the more time it's got to work and reduce your overall doses of other drugs. But I'd also like you to think, this patient's had a major trauma, their pain level's here, I need to get to that level of pain relief quickly. How am I best to do that? It's picking the right agent, moderate to severe pain matching, and using it early. So what do we have available? We can consider things such as opioids, so diamorphine, morphine, fentanyl, all suitable agents for the pre-hospital realm. We also have the potential to employ those agents via multiple avenues. So you can give all of these agents intravenously, intraosseously, intramuscularly, by and large, certainly the morphines orally, and we can consider intranasal route for fentanyl, diamorphine, and that may be the fastest way to give decent analgesia, particularly to children or those with poor access. Now, beyond that, we have the atypicals. We can use ketamine, which as a dissociative analgesic provides fantastic analgesia, particularly in the patient who's already had a significant opioid load without much effect. I'd also like you to bear in mind that in RSI positive services, giving an anesthetic for analgesia, particularly in scenarios such as severe burns, amputation, something where no amount of conscious analgesia is likely to beat the pain, is worthwhile considering early in your plan of attack. And finally, I'd like you to think about PEDS as a separate case, particularly neonates, particularly infants, because here the reassurance of mum or a family member is of paramount importance. The use of sugar, cuddling, even just a nice, warm, friendly environment can have great benefit over and above what it would have in the older child or adult. Considering a neonate suckling for the sake of analgesia is worthwhile doing with engagement with the mum and consideration for the overall injury pattern, whether it's appropriate.